Welcome to set 3 of our internal medicine review questions. If you haven't yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. These videos that I provide for you are free of cost. However, the cost that it takes to put these videos together, the time and the energy it takes, is offset by viewer donations, which I appreciate very much. If you could consider chipping in $1 a month, a little bit goes a long way to help with these videos. If you like these videos and you want to see more of them. If you do donate, you'll have access to some of my premium videos in which I go over case reviews, formulating a differential diagnosis and treatment plan, things that will come in useful for you as you get ready to study for step 3, particularly of the USMLE, which is not a multiple choice test, just like real life. And I do think that these videos will help you for your clinical practice. So thank you very much in advance for your consideration. So question 1 gives us a 64-year-old man who presented 8 months ago with gradually progressive shortness of breath, fevers, night sweats, bilateral lymphadenopathy, and weight loss. Diagnostic studies were conducted and he was placed on cyclophosphamide, adriamycin, vincristine, and prednisone. Which of the following drugs would be most appropriate to add to this patient's regimen to prevent a serious complication of his current illness and medication regimen? A. Rituximab, B. Allopurinol, C. Methylprednisolone, D. Colchicine, or E. Hydrochlorothiazide. Okay, so give you some time to pause. Now, this is characteristic of one style of USMLE question, which not only wants you to know what the diagnosis is, or what the treatment is, or what the best next step in management is, but also wants you to know what one of the complications of a disease process is, or one of the side effects of a medication. And this kind of does both. So if we look at this patient's presentation, we know that there's clearly something malignant with his presentation. He's got weight loss, lymphadenopathy, night sweats, fever, he's older. Those all point to some kind of malignancy, i.e. hematologic malignancy. But if you look at what he's on, that's a dead giveaway. So cyclophosphamide, adriamycin, vincristine, what kind of drugs are those? Those are all chemotherapy drugs. Prednisone is also commonly given in chemotherapy, but that is a steroid and it's given for other things too. So what are we most worried about in a patient who has chemotherapy drugs, particularly for hematologic malignancies? We are worried about tumor lysis syndrome. Okay, so tumor lysis syndrome, which of these drugs is going to be most useful to prevent some of the complications of tumor lysis syndrome? And if you know what tumor lysis syndrome is, you should be able to answer this. And this is allopurinol. So allopurinol is going to prevent some of the complications of tumor lysis syndrome. Now, just as a side, what does this patient have? What kind of malignancy? Hematologic malignancy, but what is his diagnosis? So you went through all this, and he had lymphadenopathy in addition to all these red flag signs, but you got a biopsy here, and what you likely found out based on the drugs that you're giving him is that he has non-Hodgkin's lymphoma, because this is CHOP chemotherapy. C for cyclophosphamide, H for hydroxydoxorubicin or adriamycin, O for oncovin or vincristine, and P for prednisone. CHOP chemotherapy, that's our treatment modality of choice for non-Hodgkin's lymphoma. Now, if you answered Hodgkin's lymphoma, you were close in name only, but that's the ABVD chemotherapies, different drugs. Now, allopurinol is going to be your best treatment to prevent tumor lysis syndrome, but not really tumor lysis syndrome, but more the complications that arise. So what is tumor lysis syndrome? Tumor lysis syndrome is simply a complication of hematologic malignancies, as well as some other malignancies. And what all it is that you have all these cells, and you're making all these abnormal cells, these abnormal tumor cells, abnormal malignant cells. And as you're making all of these cells, of course, you're having more cells that are dying. You make more cells, you have more cells dying. And so when these cells die, they spill out all their contents. And what do cells have in them? Well, any cell is going to have more potassium than outside the cell. cells have more potassium inside than is outside, higher concentration of potassium inside than outside. So they're going to spill potassium, so you're going to get a hyperkalemia. They also have phosphates. Phosphates form part of the DNA, and so you're going to get a hyperphosphatemia. And of course, since you're spilling out all that genetic material, all that DNA, there's going to be purines, and purines get metabolized to uric acid. So you have a hyperuricemia, hyperkalemia, hyperphosphatemia. You also have a hypocalcemia. And where does the hypocalcemia come from? Well, from the fact that you have hyperphosphatemia, and some of those phosphates are going to form salts with calcium, and that's going to sequester the calcium out, and you'll have a lower ionized calcium. Okay, so you get these four things. What does hyperuricemia cause? Well, if you have higher uric acid levels, you have a higher predilection for gout. And then, of course, uric acid can form stones in the kidneys. They lodge into the renal tubules, and you can get renal failure if you have enough of that. Hyperkalemia, of course, can cause arrhythmias. Doesn't take a lot to screw your heart up. And then hyperphosphatemia can also predispose you to renal failure because in this case you can form calcium phosphate stones, which is what happens when you get phosphate forming salts with calcium. And then the low calcium levels, because you have lower ionized calcium, will lead to things like seizures, tetany, and arrhythmia, your classic signs of hypocalcemia. What we're most worried about with tumor lysis syndrome, do you think we're worried about gout? No. If all the patient had was gout, we wouldn't be so concerned because you're not going to die from gout. But what you can die from is acute renal failure. Now, of course, you can die from arrhythmia, you can die from seizures, but those don't seem to be as prominent of symptoms in tumor lysis syndrome as the renal failure is. It doesn't take a whole lot of tumor lysis syndrome to develop acute renal failure. So what we're going to do to prophylax these patients, because we know they're going to get some tumor lysis, what we do is we prophylax them with allopurinol. And allopurinol is not going to prevent these cells from degrading, so you're not preventing tumor lysis. What you're preventing is tumor lysis syndrome, the signs and the complications that arise from lysing all these cells. So we give allopurinol, and what allopurinol does is it blocks the enzyme xanthine oxidase, which takes some of your byproducts of these purines and converts it into uric acid, which is then excreted out the kidneys. If you block that step, of course, you're not blocking tumor lysis. What you're doing is you're reducing the amount of uric acid in the bloodstream. And so by doing that, you reduce the amount of uric acid stones that form, and you reduce your likelihood of developing renal failure. So that is why we give allopurinol. Additionally, we want to make sure that these patients are well hydrated. The better hydrated they are, the less likely they are to develop stones because things are just getting flushed out better. And then you can give loop diuretics as well, not only to prevent overload, but also to reduce the risk of forming calcium stones. Okay, so prophylaxis with generous hydration, you may add loop diuretics onto that, and then you also want to give allopurinol. Okay, so this is how it works. You get lysis, it reduces intercellular contents, things like uric acid, potassium, phosphorus, the hyperuricemia as well as the hyperphosphatemia, which can then form stones with calcium, all lead to crystal deposition, either uric acid stones or calcium phosphate stones. That can lead to acute kidney injury. They also can get volume depletion and hypotension, along with some of these aggravating factors, which may occur with lysis or just may occur on the side with the chemotherapy. All of these things together can lead to acute kidney injury. And then with the acute kidney injury, it's going to be harder for them to excrete potassium. They're going to reabsorb less calcium, and so that's going to worsen the hyperkalemia and hypocalcemia. That can predispose them to cardiac arrhythmia and cardiac arrest. And then it's going to be harder for them to get rid of fluid because their kidneys aren't working, so they can get volume overload, and that could lead to respiratory failure. So all these awful things that come out of tumor lysis, but the one that we can help prevent is the uric acid stones. And if you can prevent the formation of uric acid stones, you can prevent the development of acute kidney injury, and you can prevent some of these more ominous features. Okay? Question 2 gives us a 20-year-old man presenting to the clinic complaining of feeling tired more than usual over the last 3 months. He has been seen twice during the last few months. He was seen in the ED 2.5 months ago, for right upper quadrant pain and malaise, but no cause was diagnosed. Review of charts from that visit reveals that there were mildly elevated transaminases, but normal alkaline phosphatase. Hepatitis serologies were negative. Right upper quadrant ultrasound did not reveal gallstones or other apparent abnormalities. The patient has no significant past medical history and has never been hospitalized. He is a full-time student and is not sexually active. He denies smoking, alcohol, and drug use. Patient appears fatigued, and physical examination is remarkable for pallor. There is tachycardia but no murmur. Lungs are cleared auscultation. There's no lymphadenopathy or hepatosplenomegaly. Abdomen is soft, non-tender, non-distended with some bruising. Labs are remarkable for a CBC, which shows hemoglobin of 6.7, hematocrit of 20.9, white blood cell count of 3.8 with normal differential, platelets of 33, MCV of 105. Reticulocytes are 0.3%. BMP and LFTs are unremarkable. Which of the following is the best confirmatory test in the diagnosis of this patient? A. Repeat hepatitis serologies. B. HIV ELISA. C. Bone marrow biopsy. D. Iron studies. Or E. Folate and B12 levels. Okay, so I'll give you some time to pause. Now, let's evaluate this patient. What stands out as abnormal? Well, one, he's got pallor, but when you look at his labs, and of course, anytime a patient has pallor or complains of being more tired than usual, you should always get a CBC. But what's standing out? His hemoglobin is 6.7. Okay, so he's anemic. But what else? His white count is low. It should be above 4.5. It's 3.8. His platelets are only 33. It should be above 150. So he is pancytopenic. That is a big problem in anybody, much less a 20-year-old, where we're really concerned. And his MCV is 105. Now, you should always look at the MCV anytime you have a patient with low hemoglobin. His MCV is 105, so you might be thinking, okay, he's got a macrocytic anemia. I need to check B12 and folate levels. Well, yes, you should. But the fact that his white count is low and his platelets are low suggests that this is not just a B12 and folate deficiency. Now, another thing you want to do when you have a low hemoglobin is you want to take a look at the reticulocyte count. If you have an anemia, you should have a high reticulocyte count. It should be above 2%. And if it is, then that shows that the bone marrow is responding to his anemia. If it's not above 2, if it's low, then what that's telling you is that the bone marrow is not responding. Okay, so what we're going to do is we are going to get a bone marrow biopsy because there is something wrong with the bone marrow. He's not making his cell lines properly, and the reticulocyte count is low, showing the bone marrow is not responding. Now, at this point, you may know what the diagnosis is. So let's go on to our next question, which relates to the same patient. Now, this is characteristic of the USMLE. They'll give you a question like the one I gave you before, and then you won't be able to go back and change your answer because now they're going to give you the results of that most appropriate test. So the patient has been admitted and he receives transfusion, hopefully he doesn't refuse it, receives transfusion with leukocyte-reduced O-negative blood. Bone marrow biopsy reveals hypocellularity and abundant adipocytes. There's normal cellular morphology, so the cells that are there are normal. No other abnormalities. Which of the following is the most appropriate treatment for this patient? A. Bone marrow transplant. B. Broad-spectrum antibiotics. C. Erythropoietin and GM-CSF. D. Prednisone. Or E. Anti-thymocyte globulin and cyclosporine. Okay, so this is actually now going to require you to know what the diagnosis is. And in order to know the diagnosis, you need to understand a little bit about pathology. Now, on step 2 and 3, you're not going to have to know pathology as far as what it looks like. You're not going to be given pictures. But what you will be given occasionally is a description of some particular biopsies. Now, it'll be pretty basic, and if you knew your step 1 stuff, you should be good. Step 1, they'll give you pictures. You'll need to know much more than this, but you won't need to know as much about diagnosis and management. Okay, so what is our answer here? The answer is a bone marrow transplant. So what's our diagnosis? Our diagnosis is aplastic anemia. I didn't give you anything else. All I need to do is give you the results of the bone marrow biopsy, and you should know this is aplastic anemia. Aplastic anemia is a failure of bone marrow. And the bone marrow is not producing cell lines as it should. And in this case, you have a paucity of precursor cells. What would we expect to see in the bone marrow in a patient who's got pancytopenia? Let's just say you take a bunch of blood out of a patient, replace it with plasma, and they're pancytopenic. You would expect to see abundant cells in the bone marrow. They're going to be working overtime to replace all those cells that have been lost. But this guy not only has a pancytopenia, but his bone marrow is not working. So we know where the problem is. It's in the bone marrow. That's why we call it aplastic anemia, because the bone marrow is not working. So the treatment for aplastic anemia for a person under the age of 50 is a bone marrow transplant. We want to find a match for him, ideally a sibling or an identical twin if he's got one. Most people don't. But ideally a sibling. Now we have, of course, all those programs, the Be a Match and all those things, where you can put them into a database and see if you can find somebody. But ideally it would be a sibling. But you need to find an HLA match for him. If you can't do that, or if the person is over the age of 50, then the answer would be E, antithymocyte, globulin, and cyclosporine. But the bone marrow transplant is best for a patient under the age of 50. It's got about an 80% response rate. 80% of these patients will have a sustained remission. Okay, now why not broad-spectrum antibiotics? Well, broad-spectrum antibiotics are not going to help you because this patient doesn't have an infection. And now at some point down the line, the patient may develop an infection because he's got a low white count. But it's not going to help you in this patient because antibiotics are not useful for a patient who doesn't have an infection. He doesn't have any apparent infection. Erythropoietin and GM-CSF, why not that? Well, you might be thinking, well, this guy's got a low hemoglobin and a low white count. GM-CSF, by the way, is granulocyte macrophage colony stimulating factor. It helps you boost your white count. But you could give them that all day, and it's not going to help because what this does is it stimulates the bone marrow. But if your bone marrow is not working, this stuff is not going to help you at all. A lot of times we give erythropoietin to people with chronic kidney disease who get an anemia from that because they're not making erythropoietin and they're not stimulating their bone marrow, and this replaces that and helps them stimulate their bone marrow and make more red cells. But with them, their bone marrow works fine. For this patient, not going to help whatsoever. Prednisone. Prednisone is actually used as a sort of last-ditch treatment because the idea is that with a lot of patients with aplastic anemia, there's an autoimmune origin, so prednisone is given, but it's not a great treatment for aplastic anemia. So bone marrow transplant, then antithymocyte, globulin, cyclosporine, or you could use tacrolimus in replacement of cyclosporine, and then prednisone is sort of your last ditch. So aplastic anemia is bone marrow failure, which can be either idiopathic, as it is in most cases. Usually when they say idiopathic, it's an autoimmune origin, but we don't really know, obviously, because it's idiopathic. Or it may be due to secondary factors. So it could be chemotherapy and radiation. Might be getting chemotherapy for a different cancer, like lung cancer. You get the radiation or the chemotherapy, and now all of a sudden they develop pancytopenia and they have aplastic anemia. It could be due to toxins, things like toluene, insecticides, benzene. So you want to get an employment history if they work in chemical processing. Sometimes they can be exposed to some of those things. Farmers can be exposed to insecticides. And then like certain drugs, which I'll give you a list of those in a little bit. Aplastic anemia invariably results in a pancytopenia, and the symptoms are reflective of pancytopenia. So they get anemia, they get, they're predisposed to infections, they get, because of the low platelet count, predisposure to bleeding, and like gingival bleeding and bruising. Notably, there's no hepatosplenomegaly or lymphadenopathy. Now, what would you expect to see hepatosplenomegaly and lymphadenopathy in? You would expect to see that in like leukemia, where in leukemia, you get an infiltration of the bone marrow. And so you can get a pancytopenia from leukemia, but you will also get infiltration of either the bone marrow, or you can get infiltration of the liver or of the spleen. And so that would cause a hepatosplenomegaly. You can get lymphadenopathy from that too. So if you have hepatosplenomegaly or lymphadenopathy, it's not aplastic anemia. It's probably a leukemia or something like that. So with aplastic anemia, there's never hepatosplenomegaly or lymphadenopathy. So pancytopenia or anemia in the absence of an apparent cause should trigger a bone marrow biopsy, which is diagnostic. So as mentioned, When you have that pancytopenia, you should always be thinking bone marrow biopsy as your next step. Okay, so pancytopenia, what are the different causes? Aplastic anemia obviously is a big one, and of course you'll diagnose pancytopenia on CBC. Some other ones are myelodysplasia, acute leukemia, myelofibrosis, these sort of malignant processes, infiltrative diseases, which we talked about. It can also cause pancytopenia, but remember with these infiltrative diseases, you'll tend to have more likely have a hepatosplenomegaly, and then megaloblastic anemia. So with megaloblastic anemia, the problem is you're not getting folate and B12, and those are necessary precursors to make blood cells. So if you have a really severe deficiency in B12 or folate, you don't have the things that are necessary to make these cells, and so that can cause a pancytopenia, but it typically has to be very severe. The confusion, though, can come when you have aplastic anemia. You can also have large red blood cells, and it drives your MCV up, as we saw in this patient. So this patient could have just as easily had a megaloblastic anemia, but you couldn't rule out aplastic anemia, so that's why you need to get the bone marrow biopsy. And then there are non-marrow disorders like hypersplenism. So if your spleen is big, it's going to sequester more blood cells, and so it's not that you technically have a pancytopenia, it just comes back that way on CBC. You have fewer circulating cells. Systemic lupus, and then infection. The big one here is parvovirus B19. You'll especially see, not just anybody gets a parvo B19 infection and develops aplastic anemia. This is typically people with hemoglobinopathies. Now, if you have aplastic anemia, what's the cause? Well, rarely in pediatrics you'll see congenital aplastic anemia, but that's not common. Most of the time it's idiopathic. Occasionally it's secondary, so some autoimmune disorders like systemic lupus and PNH. Chemotherapy and radiation, certain toxins like benzene, toluene, and insecticides, so those are often occupational exposures. Drugs, a lot of these aren't used anymore, so chloramphenicol is an old antibiotic, not very commonly used anymore. Phenylbutazone is an old NSAID, not FDA approved anymore except for in the treatment of ankylosing spondylitis. Gold salts is an old means of treating RA, not used very often anymore. Sulfonamides, obviously used, not uncommonly. Phenytoin or dilantin, used commonly for the treatment of seizures, epilepsy. Carbamazepine, also used for epilepsy as well as bipolar, that's Tegretol. Quinacrine is an old malaria drug, not used very often. And then tolbutamide is not used that often anymore. That used to be used for diabetes. They can also get aplastic anemia after having a hepatitis episode. That doesn't necessarily need to be a viral hepatitis. Occasionally you can have hepatitis and it doesn't come back positive on hepatitis titers, which may have been the case in our patient. So just look for any history of right upper quadrant pain. And then pregnancy. So this is how bone marrow looks normally. You see that there is normally some adipocytes, but there's a decent amount of cells, these precursor cells here. This is what it looks like with aplastic anemia. So much fewer cells and much more adipocytes. The management for aplastic anemia, if the patient is under 50, it's a bone marrow transplant. If the patient is over 50 or there's no match, it's antithymocyte globulin and cyclosporine. You want to refer these patients to heme-oncology. You don't want to just give transfusions willy-nilly. You want to make sure that you're only giving it when it's absolutely necessary. And the reason for that is if you're giving blood products, that may affect their ability to respond to bone marrow transplants. So you want to be careful. That's why these patients need to be referred to a specialist. Patients should be admitted if they have any infections. Question 4 gives us a 35-year-old woman who presents to the ED because of worsening fatigue and altered mental status. She was her normal self yesterday afternoon, aside from some right foot pain, which coincided with stepping on a splinter in the backyard. Since yesterday, she has become increasingly tired and was running a fever of 100.5 degrees Fahrenheit last night. She woke up this morning at 5 a.m. confused and disoriented. Vitals show a blood pressure of 98/70, heart rate 110, respirations 14, temperature of 103.6, saturation of 100%. There is an obvious 1 centimeter ulceration on the sole of the right heel, surrounded by a dusky purple discoloration of the surrounding tissue. The foot is exquisitely painful. Blood cultures are taken and IV fluids are started. CT of the affected foot reveals soft tissue gas and fluid collections in the deep fascia. Which of the following is the best next step in management of this patient? A. Parenteral clindamycin. B. Parenteral penicillin. C. Parenteral vancomycin. D. Surgical debridement. Or E. Hyperbaric oxygen therapy. Alright, the answer to this one is D. Surgical debridement. So our presumptive diagnosis in this patient is necrotizing fasciitis. Your management of necrotizing fasciitis, first off, whenever the patient comes in, you want to make sure they're hemodynamically stable, because what are they predisposed to? They're just predisposed to sepsis. We want to make sure that they're stable. She's a little hypotensive, but she's okay. She's 98/70. So she's got some signs of sepsis setting in, but there's nothing hemodynamically that we need to do for her. So the very next step is to get our basic labs. That's going to include CBC, BMP, blood cultures, ABGs, because we want to measure her level of sepsis, and then we want to get cultures and stuff like that to check for infection, because clearly there's going to be something in her blood. We also want to get cultures of the wound. Once we do that, however, it's very important to do two things: to start antibiotics and to debride the patient. Now, if these antibiotics were a little different, then the best next step in management would be to give antibiotics and to do surgical debridement. But none of these antibiotics are appropriate by themselves. Okay, so you can't give any of these alone. So that's why none of these are the right answer. Surgical debridement out of all of these would be the best very next thing to do. Hyperbaric oxygen therapy may be considered at some point, but antibiotics and surgery need to be done first. The literature actually has suggested that oxygen therapy does improve survival and morbidity. But the reason A, B, and C are not correct is, as we're going to see, you need broad spectrum antibiotics, and that never means one antibiotic. That means more than one. Okay, so let's go on here. So necrotizing fasciitis is a rapidly spreading infection of the subcutaneous fat and fascia. Risk factors include anything that increase your risk of infection, so diabetes, peripheral vascular disease, burns, trauma, immunocompromised states, and IV drug use. The signs: locally, there's pain beyond the margins. Okay, so look at where the wound is. Okay, so here's our wound. There's usually very dusky purple margins, discoloration, and then there's erythema even further around that. Now, when you get to this normal tissue, typically that tissue is also painful. Now, obviously, this tissue here is going to be painful because it's erythematous. But even if you were to go up even further, there'd be some pain. Okay, so pain beyond the margins of the apparent wound area and the affected tissue. Often you'll see some level of necrosis, and if you palpate to the degree you can, you may feel crepitus, which is that sort of bubble wrap feeling underneath. And that's air underneath the tissue, which we see when we do a CT. Systemically, they can have signs of infection, fever, tachycardia, hypotension, sepsis, including toxic delirium, which we saw in this patient with the altered mental status. So the management is hemodynamic stabilization. If necessary, you want to start IV fluids no matter what, just in case they go septic and hemodynamically unstable. So you want to get a large bore IV catheter in. You can put fluids in as needed. You get sepsis labs. That includes CBC, BMP, ABGs, urinalysis, blood and tissue cultures. You want to start broad spectrum antibiotics and then get surgical debridement. And what do we do for broad spectrum antibiotics? Basically, you want to use a penicillin, an aminoglycoside, and something that covers anaerobes. So penicillins could be things like penicillin G, ampicillin, and those cover gram-positives. An aminoglycoside would be things like gentamicin, tobramycin. Those cover gram-negatives. And then usually you'll use clindamycin in addition to those two things. Clindamycin not only covers gram-negatives, but it's great. It's indispensable for covering anaerobes. Okay, so you put those all together, and you've got very good broad spectrum. So something that you might do is ampicillin, gentamicin, and clindamycin. You see amp-gent a lot in the hospital. It's really good broad-spectrum coverage as long as you're not suspecting anaerobes, but you want to add clindamycin to cover anaerobes. You could also do vancomycin if you're suspecting MRSA. Okay, so this is the most common regimen, penicillin or ampicillin plus an aminoglycoside plus something with anaerobic coverage. Clindamycin, I would say, is more common. Metronidazole could be used as well. You could also try one of these drugs that have a combined extended spectrum penicillin with a beta-lactamase inhibitor. So you see these occasionally: ampicillin sulbactam, tetracycline clavulanate, piperacillin tazobactam. These three, I think, are seen probably the most. So you could also use those. But I would say for the test, I would remember a penicillin, an aminoglycoside, and clindamycin is best for broad spectrum coverage for these soft tissue infections. Okay, question 5 gives us a 37-year-old woman who presents to your clinic complaining of low back pain, which has been going on over the last week. She denies trauma and heavy lifting, and the pain is localized roughly to the level of L3. There's no associated numbness or tingling of the lower extremities and no bowel or bladder incontinence. The pain is sharp, constant, rated as a +6 out of 10. There's nothing she can think of that worsens or improves the pain. Her past medical history is significant for RA, which was diagnosed over 1 year ago. Medications include diclofenac and prednisone, as well as a multivitamin. Vitals are within normal limits. Physical exam reveals point tenderness over the affected bone, which does not elicit any other symptoms. There are no gross abnormalities of the back. The remainder of this physical exam is normal. Which of the following is the most likely cause of this patient's symptoms? A. Lumbar disc herniation. B. Spinal stenosis. C. Spinal compression fracture. D. Spinal neoplasm. E. Ankylosing spondylitis. Or F. Myofascial strain. Alrighty, the answer to this one is C. A spinal compression fracture. So back pain, lower back pain especially, is a very extensive differential. But there are a couple things about this patient that push us towards a spinal compression fracture. Now you can approach this question in one of two ways. You can work by elimination, or you can look at the patient's profile and figure out which one of these is most likely. I like to look at it both ways. So first of all, lumbar disc herniation, spinal stenosis, and then, those two. Those are both going to give you neurologic symptoms because typically they both cause some level of inflammation or impaction on the spinal nerves. So this patient doesn't have any numbness or tingling of the lower extremities, so there's probably nothing going on with the nerves, nothing impinging upon the nerves or causing inflammation around the nerves. Spinal neoplasm could possibly be the case, but spinal neoplasm typically will, the patient will have like a history of some kind of previous malignancy, or they'll have symptoms of cancer. So your constitutional signs like unintentional weight loss or fever and night sweats and all that stuff. Okay, so that's not as likely. Ankylosing spondylitis. Well, this comes down to the patient's sex and age. Ankylosing spondylitis, if this were a 25-year-old guy, would be certainly a possibility. Now, there are some things that work against ankylosing spondylitis regardless. Ankylosing spondylitis tends to be worse in the morning and gets better throughout the day. There also won't be point tenderness. The pain is more generalized through the lower back. There's also tends to be hip pain and knee pain, and there may be some systemic signs and maybe a history of things like uveitis. So that's less likely. And then myofascial strain. This is very, very common. Myofascial strain is a tremendously common cause of lower back pain. It's associated with a myriad of causes like muscle overuse and sleep position. So that's a possibility. But what do we see here in this patient? There's point tenderness over the bone. That suggests something wrong with the bone itself. Now, if there was paraspinal tenderness, like of the muscles, that would suggest more of a myofascial strain. But look at this patient's history. She's on steroids. And what do steroids do? They weaken the bone. Steroids weaken the bone. And so you're going to be more likely to develop an osteoporotic-like fracture. Now, if this patient were a 68-year-old woman, she wouldn't even need to be on steroids. She'd be at risk for spinal compression fracture just by virtue of her age, and she probably would have an osteoporosis along with that. Okay? So let's look at low back pain. So the very first step in evaluating low back pain is to determine whether or not there's neurologic signs associated with the back pain. Okay, so the one thing you want to ask them is, do you have continence of your bowel and bladder? And a lot of patients, if they have bowel or bladder incontinence or retention, well, that will be their chief complaint. And then you'll see back pain along with that. That is a sign of cauda equina syndrome. Okay, so back pain, in addition to these autonomic issues like bowel and bladder incontinence, that is a sign of cauda equina syndrome. And that is an emergency. That's going to require immediate surgery. Now, there's something you can do called a straight leg raise test. And all you're doing is you're having the patient lay down on the exam table and raising their leg. It's quite simple. If there is pain, if that replicates their symptoms, then that is suggestive of spinal nerve irritation. And that can be due to disc degeneration or herniation, as well as stenosis. Now, with stenosis, with spinal canal stenosis, which we saw here, one of the characteristics of spinal stenosis is that the pain is relieved with sitting. So when they're walking, especially if they're walking downhill, the pain will be worse with doing those things. But if they go to sit down, it gets better. That's classic of spinal stenosis. And spinal stenosis is a consequence of severe disc disease. Now, what causes disc degeneration? Typically, it's due to old age. Okay? As you age, you lose water in the annulus, and that causes weakening. And over time, you get collapsing, and that causes the spinal bodies to compress upon one another, and that can lead to stress on the spinal nerve. Now, you can get herniation from degeneration, but you can also get herniation from like lifting something really heavy very suddenly, and that can cause herniation, and the herniation can cause nerve root irritation as well. But either way, it's going to lead to neurologic signs, and so that will be a positive straight leg test. Now, on the other hand, if the patient has systemic signs, that suggests a systemic process. So things like fever, night sweats, and weight loss, that may suggest a spinal metastasis from another primary tumor, or it can suggest TB. You can get tuberculous inflammation of the bone, and that is known as Pott's disease. TB, not very common in the US, though. Fevers, chills, and septic signs can be a sign of osteomyelitis, so you get an infection of the bone. Morning stiffness, pain at other joints, acute anterior uveitis is a sign of ankylosing spondylitis, so look for that lower back pain in a young guy. Fractures should be suspected in older women and in patients on steroids, like what we saw in our patient here. So for diagnosis, it's going to be clinical if there's no neurologic or systemic signs and if there's no suspicion of cancer or infection. So 93% of patients with low back pain will just have back pain only, no systemic signs or anything like that. Okay. If there are autonomic or bilateral neurologic signs, that suggests a stenosis or a possible cauda equina syndrome. So in that case, you'll want to get an MRI. You'd also want to get an MRI if you're doing conservative management and the patient has not improved after 6 weeks. You get an X-ray or CT if you suspect osteomyelitis, fractures, ankylosing spondylitis, or metastasis. Okay, so back pain only, you want to look for systemic signs, history of cancer, neurologic signs. If there's none of that, you don't need to do any diagnostic tests. Just do rests, NSAIDs, and follow up in 6 weeks. If they have just back pain itself and they do have systemic signs or history of cancer, you can get a SED rate. A SED rate would tell you if there's inflammation, which would be a sign of some kind of systemic process. And then if that comes back positive, you can get an X-ray, CT, something like that. If they do have signs of sciatica, What you do want to know is whether or not there's bilateral signs, whether or not there's bowel bladder involvement, or if there's saddle anesthesia. Some of those things would point, like the bowel bladder signs, saddle anesthesia would point towards cauda equina syndrome. If that's the case, get an MRI and a surgical consult. If not, you can do rest and NSAIDs and or an MRI. And then you want to look for spinal stenosis. So spinal stenosis, it's classically relieved with sitting and rest. If you can get an MRI, or you can treat that conservatively. An MRI would be good, especially if it's not responding to conservative therapy or if they have intolerable pain. The management for cauda equina syndrome, or for spinal stenosis, or for spinal nerve involvement is a surgical workup. Whether or not they get surgery is questionable. Cauda equina syndrome, though, they always will. Disc degeneration typically comes with age. There's not a whole lot to do with it. NSAIDs, rest, and physical therapy. Ankylosing spondylitis, remember, young guys, it's one of those seronegative spondyloarthropathies. NSAIDs, TNF inhibitors, and physical therapy. Compression fractures, like in our patient, NSAIDs, rest. Rest is the only thing that's going to help any kind of stress fracture. And workup for osteoporosis is necessary. And then myofascial strain, we do NSAIDs and rest. Okay, question 6 gives us a 47-year-old man who presents to your clinic complaining of weakness over the last month. On review of his chart, you note that he was seen 2 months ago for acute alcohol toxicity after he was found drunk on the streets by the police. His past medical history is significant for long-term alcohol abuse. He says he drinks about a quarter liter of vodka every day. That's a lot. He smokes a pack per day, but denies illicit drug use. He does not take any medications. Vitals are within normal limits. Physical exam is remarkable for ecchymoses and some pearly white papules around the hair follicles on the arms and legs. Dentition is normal, but there's some bleeding of the gums. There are no murmurs. Lungs are clear to auscultation. Abdomen is soft, non-tender, non-distended, grossly intact neurologically. So you get labs, you get CBC, BMP, liver function tests, and PT-PTT, which are unremarkable. Which of the following is the most likely diagnosis in this patient? A, vitamin A deficiency, B, vitamin B1 deficiency, C, vitamin B12 deficiency, D, vitamin C deficiency, E, vitamin D deficiency, or F, vitamin K deficiency. Okay, so you want to know your vitamin deficiencies for the USMLE, without a doubt. And they don't really have any rhyme or reason to the letter of the vitamin, so you really just have to memorize it. So what does this guy have? The answer is scurvy. He's got scurvy, vitamin C deficiency. So you might look at this question and think, well, he's bleeding, and he's bleeding from the gums. That's gingival bleeding, and that is something that you would expect to see perhaps in vitamin K deficiency, because we know vitamin K is associated with the with bleeding. So why is this not vitamin K deficiency? Well, first off, you can get bleeding in scurvy, which doesn't really make any sense when you first think about it, but I'll explain it. But vitamin K deficiency, we tend to see an increased PT, and we don't see that in this patient. So that's less likely. Okay, if he had vitamin K deficiency, he would probably have an increased PT, almost certainly. So with vitamin C deficiency, you can get bleeding. Why do you get bleeding with vitamin C deficiency? Well, it's not so much that you are bleeding more, so much as it is that vitamin C is very, very important for your connective tissue, for collagen. And so if you're not getting enough vitamin C, the tissue is going to be weaker. And so if you have weaker tissue, it's going to be much easier to bleed, because just a little bit of trauma, like for instance from flossing, although I doubt this guy flosses because it appears he doesn't take very good care of himself. But if you have a vitamin C deficiency and you go in and floss, you can get bleeding because the tissue is weaker. Okay, so that's why you can get bleeding from scurvy. Okay, so vitamin A deficiency. Why not vitamin A? Vitamin A is your eyes. Okay, so you're going to get night blindness, keratoconus, xerosis. You can get those little white spots on your conjunctiva called Bateau spots. So this is not vitamin A deficiency. Vitamin A is one of the most common vitamin deficiency syndromes worldwide, but we don't see it so much in the US. Vitamin A is a little bit easier to get in our diet. Vitamin B1 deficiency, that's thiamine, and thiamine certainly can show up in alcoholics, thiamine deficiency. A lot of these vitamin deficiencies can show up in alcoholics, but you do see thiamine deficiency a lot in alcoholics. That's the Wernicke-Korsakoff syndrome. So Wernicke's encephalopathy is going to give you disorientation, inattentiveness, confusion, and then the Korsakoff syndrome can give you dementia. You get those confabulations where you don't remember things, but you make up things to fit in. And so Wernicke-Korsakoff is seen in the thiamine deficiency, B1 deficiency. See it commonly in alcoholics. Vitamin B12 deficiency, that's the one that's going to give you the megalocytic anemia. It's going to give you the decreased proprioception and vibratory sensation in your feet and hands. So this is mostly neurologic symptoms, and then anemia. Vitamin C deficiency we talked about. Vitamin D deficiency, remember, vitamin D is very important for calcium, and so you're going to see in little kids, you're going to see rickets. In adults, you're going to see osteomalacia. So it simulates calcium deficiency. These patients are going to be at risk for incidental fractures. And then vitamin K deficiency is going to be the bleeding issues. Petechiae, ecchymoses, oozing of blood at surgical sites, menorrhagia, bloody nose, commonly seen in infants, so now we give them vitamin K injections after they're born to reduce their risk of developing a vitamin K deficiency. So scurvy is a deficiency of vitamin C characterized by weakness. Unfortunately, weakness is probably the most common symptom, but it's very nonspecific, so it's very difficult to parse that out. Bleeding, as we mentioned, because of the reduced integrity of the tissue. Why gingival bleeding? The gingiva is just really delicate tissue, so it doesn't take a whole lot of vitamin C deficiency to make this tissue very friable. So you can see in this patient, there's blood. They can get infection, and then because vitamin C is an antioxidant, and then poor wound healing, again, along the lines of tissue. So it's associated with alcoholism as well as poor or unusual eating habits. A lot of the patients you'll see scurvy in are little kids, and little kids can have sort of finicky, picky eating habits, and a lot of times the parents, they don't know any better, and they'll just give their kids what they'll eat. And so they may be stuck to like white bread and maybe meat or something not very, very unusual, not very balanced diet. And so you always want to ask about the diet, especially if it's a little kid, because sometimes parents just don't know any better. And then there may be some signs that are recognized on the x-ray, especially in the long bones, but I'm not going to go into that. I did a whole lecture on scurvy, so if you want to go back to my review videos on YouTube, you can see the lecture that I did on scurvy. So this is your vitamin deficiencies. A couple of them I didn't put in, like folate, but these are the ones that you definitely want to know for the test. I highlighted the ones in red here that I think come up more commonly in test questions, so you can refer to this if you want. One I do want to bring up very quickly is vitamin B6. If you get it on a test question, you may get a patient with TB who's given isoniazid, which is a common TB drug. Isoniazid is also given to patients who show up wind up reactive on their TB test, and then they give them isoniazid for 9 months to try to clear it out. And you need to give vitamin B6 with isoniazid. You give the two together, because isoniazid, if you give it alone, will dramatically raise your risk of getting a vitamin B6 deficiency. Okay. So question 7 gives us a 44-year-old woman seen in the hospital for endoscopically diagnosed H. pylori negative peptic ulcer disease, which has been refractory to medical therapy. You get a fasting gastrin level on her, and it reveals a elevated level of 850 picograms per milliliter, where normal for fasting is less than 100. Somatostatin receptor scintigraphy detects a mass in the pancreatic head, which is subsequently removed by surgery. Gastrin levels are repeated and found to be 78 picograms per milliliter. That's a fasting gastrin level. Again, it's 78 now. Which of the following is most likely to develop in this patient? A. Hypercalcemia. B. Elevated calcitonin levels. C. Yellowish white painless nodules in the oral mucosa. D. Elevated vanillomandylic acid levels. Or E. Pancreatic adenocarcinoma. I'll give you some time to look at this here. If you can get this one right, you're sitting really good for the test, I would bet. This is a tough one. All right, so you can pause. Otherwise, I'm going to give you some hints now. So first way to go at this question, this is asking you what's most likely to develop, meaning that there's other things that this patient may be susceptible to. And anytime you have a patient that's susceptible to multiple things, what do we call that? We call that a constellation, like a syndrome, where you can get multiple things that develop together. Not necessarily, but you have one thing, you're at risk for developing another thing. Okay, so what do we call this that this patient has? This has a name. This syndrome has a name. First off, just this thing going on in her pancreas. This has a name. That she's getting this thing in her pancreas and now she's getting ulcers in her stomach and duodenum. Okay, so we call this Zollinger-Ellison syndrome. Okay, what all that is it's a gastrinoma. It's a tumor that is all by itself secreting acid. Secreting gastrin. Okay, so it's an independent gastrin-secreting tumor. Now, normally we secrete gastrin after a meal. Okay, because remember what gastrin does is it tells your cells to make acid, and so you can digest what you just ate. But in her, she's got a tumor that's secreting acid autonomously, all by itself. And so that's why her gastrin levels are high, even though she's fasting. She's not eating anything. Normally, when we fast, our gastrin levels should go down. Now, we use this somatostatin receptor scintigraphy to look for where this gastrinoma is. We know she has a gastrinoma because she's got a very high gastrin level when she's fasting. So now we want to look to see where it is so that the surgeon knows where to look when they go to remove it. And so we do this scintigraphy, and what it finds is that there's a mass in the pancreatic head. Now this is diagnosed Zollinger-Ellison syndrome. Okay, and the gastrinoma could be in the duodenum, or it can be in the pancreatic head, or it can be elsewhere. But typically it's in the duodenum, but in a large minority of cases it's in the pancreatic head. Okay, but that's not so important. What you know is that there's a gastrinoma, and she's got Zollinger-Ellison syndrome. Now, what is it when you have a tumor of the pancreas, okay, that's secreting gastrin? Is that a pancreatic cancer? No, this is a benign tumor. It's a functioning tumor. Functioning tumors typically aren't benign, or typically aren't cancer, although they can be. Okay, so this is a benign tumor that's just secreting gastrin. And so this is a pancreatic tumor, though nonetheless, even though it's not cancer, it's a pancreatic tumor. Now, what are some syndromes that are associated with a pancreatic tumor? Okay, remember, this is an endocrine tumor. Gastrin is a hormone, and so this is an endocrine tumor. So what do we think of when we hear about endocrine tumors or endocrine neoplasia? We think of multiple endocrine neoplasia syndromes. There's 3 of them, MEN1, MEN2A, and MEN2B. And so what is this? A tumor in the pancreas. Is that part of MEN1, MEN2A, or MEN2B? MEN1. Okay? MEN1 is pituitary, parathyroid, and pancreas. The 3 Ps. And so which of these is pituitary or parathyroid? Probably A or B. Okay, C looks a lot like mucosal neuromas, and D looks a lot like, well, it's increased vanillomandylic acid, so it's probably a pheochromocytoma. Okay, so C and D are out. And E is out because this isn't a cancer, and having Zollinger-Ellison does not raise your risk of cancer. Okay, that's not part of the MEN syndromes. So A or B? Well, hypercalcemia would be parathyroid hyperplasia. And elevated calcitonin levels would be a thyroid tumor. So only A is a thyroid cancer. I'm sorry, parathyroid hyperplasia. B would be a thyroid cancer. In particular, this is medullary thyroid cancer. Calcitonin has something to do with the calcium levels, but it has more to do with lowering your calcium levels. Now, you might make an argument that you can have elevated calcitonin levels if you have hypercalcemia. And so if that was your line of thought, you're half right. But you're definitely going to see an increased risk of hypercalcemia in this patient because if you have parathyroid hyperplasia, you're always going to have hypercalcemia. Okay, so the answer is hypercalcemia. Okay, so MEN1, which is what this patient has, pancreatic tumors, Zollinger-Ellison syndrome with one of those gastrinomas, very, very high risk of MEN1. Is pituitary adenoma, parathyroid hyperplasia, and pancreatic tumors. Okay, those three. And these are the three Ps, pituitary, parathyroid, and pancreatic. MEN2A, I like to remember, is the three Cs. Parathyroid hyperplasia, medullary thyroid cancer, and pheochromocytoma. How do you remember this? Parathyroid hyperplasia is going to give you the elevated calcium. Medullary thyroid cancer is elevated calcitonin, and pheochromocytoma is elevated catecholamines. Okay, so elevated calcium, elevated calcitonin, and elevated catecholamines. And then MEN2B is the big belly. Okay, so they're big, marfanoid body habitus, and there's things that can go on in their belly, pheochromocytoma. That I got from somebody else, so I don't like that mnemonic as much, but if it helps you, that's good. MEN2B is the only one that gives you mucosal neuromas and a marfanoid body habitus. Okay, so you can't diagnose MEN2B unless you have one of those, because otherwise you just have the medullary thyroid cancer and the pheochromocytoma, and that can be a MEN2A and MEN2B. So that's why this is A and B. They're both MEN2, because MEN2 is going to give you both the medullary thyroid cancer and the pheochromocytoma. But A is going to give you parathyroid hyperplasia, and B is going to give you the neuromas and the body habitus. Okay. All of these are autosomal dominant. Okay, question 8. An 18-year-old woman with known type 1 diabetes mellitus is brought to the ED by her roommate because of protracted vomiting and abdominal pain, which has been going on for 8 hours. Her roommate says that the patient has been very busy studying for finals and has also been fighting off a strep throat infection for which the patient was seen and received antibiotics 5 days ago. Normally, the patient tests her blood sugar regularly, but has not so much recently because she's been so busy. Vitals are 100/70, heart rate 110, respirations 15, temperature 100.4 degrees Fahrenheit, saturation 98%. Stat labs were obtained and are significant for a blood glucose of 650 milligrams per deciliter, sodium 128, potassium 2.9, bicarb 13, chloride of 91. Positive for ketone bodies. Which of the following is the best next step in management? A, IV normal saline, there's 0.9% sodium chloride. B, IV 3% sodium chloride. C, IV potassium. D, IV 5% dextrose in half normal saline. Or E, IV glucose and insulin. Okay, so this is your management of a particular complication of type 1 diabetes. So you want to know the first thing you do. You always want to know the first thing to do. Get the first thing to do, then you can always go back and in real life go look at your notes or your little pocket book and find out what you should do after that. But you want to know what to do with this patient first. Okay, so the answer here is A. You want to give her normal saline. Why do you want to give her normal saline? Well, first of all, her sodium's low, so shouldn't we be giving her 3% sodium chloride, some hypertonic saline? We don't give hypertonic saline unless there's a serious, serious drop in sodium level. And even then, we want to make sure that the patient is stable before we even monkey around with hypertonic saline. You probably won't be giving hypertonic saline. That's usually the domain of a nephrologist. But even with a hypertonic saline, you typically don't give it until it's much lower. And 128 is not that, it's low, but it's not that low. Okay, so you're not going to be giving her hypertonic saline. And usually we only give hypertonic saline if there are some symptoms of hyponatremia present. So not B. Well, what about IV potassium? Her potassium's low, 2.9. Okay, so why not that? Well, again here, the most important thing to do for this patient is to stabilize her. Okay, she's been vomiting, she's sick, she's got a high glucose level, and so we want to stabilize her. The potassium is not so important right now. Now, anytime the potassium is lower than 3, we're typically going to be giving potassium. Okay, but not right now. Okay, it's 2.9, but there's other things we need to do first. What about dextrose and half normal saline? We don't want to be giving her sugar right now, and half normal saline is not appropriate for volume resuscitation, so we don't want to do that. And then IV glucose and insulin. Yes, we're going to do that at some point, but not now. Actually, we're going to be doing C, D, and E all at one point during her treatment, but the first thing you do in the treatment of a patient with, what does she have? What does this patient have? What's the name of this process that's going on? Diabetic ketoacidosis. She's got ketone bodies. We don't know if she's acidotic, but look at that bicarb. It's really low, so she's probably acidotic. You need a blood pH to determine that definitively, but this is DKA. Okay, and the very first thing you do in treatment of DKA or in HHS, I always get this hyperglycemic, hyperosmolar, HHS. So what do we do in DKA? We do volume resuscitation. Same with HHS. All right, so the presentation of DKA. Typically they come in with some kind of acute illness. Usually it's going to be abdominal pain they'll complain of, but they may have vomiting in many instances. Because of the abdominal pain, it's not because of any infection necessarily, but it's the abdominal pain that causes the abdominal pain causes the vomiting. Anything that gives you really bad abdominal pain can cause vomiting. I don't know why. They tend to be dehydrated. As a matter of fact, you should assume any patient coming in with DKA is dehydrated. And so the very first thing you do is you're going to volume resuscitate them. Of course, known history or features consistent with type 1 diabetes. This may be the presenting feature for diabetes because if the patient's ever been diagnosed with diabetes, they're not going to be getting insulin, and so they can become ketoacidotic. So look for features consistent with diabetes, history of excessive urination, history of excessive thirst, weakness, increased appetite, etc. And then these Kussmaul respirations, these unusual deep respirations. Didn't see that in this patient. This is a very, very, very late sign of acidosis. So what do you do for workup? Well, if you're suspecting DKA, any patient who is a diabetic who's having some kind of an acute illness, you want to get a fingerstick glucose, get a CBC, get a BMP, get blood cultures. Because of the possibility of infection, infection can elicit a DKA episode, so you want to get blood cultures. Serum and urine ketones, those should be positive. Urinalysis and culture, especially in girls and women, having a bladder infection can precipitate a DKA episode. Arterial blood gases, you might be able to do without this, frankly. ABGs are so painful, especially if you've got a little kid. You don't want to put them through ABGs, but for the test, ABG is fine. And then EKG. Why? Because they tend to be, so this is a little bit complicated, but with DKA, they may come in with a high potassium or they may come in with a low potassium. In any instance, their body is potassium depleted. But because of the low insulin levels, they may have a high potassium because they're not drawing potassium into their cells. But either way, you should assume low potassium. So you should be aware of that. But if they're high potassium or low potassium, they may have findings on their EKG, and that would be an indication that you need to do something about it. But they will become low potassium if you, as they go on. When you give them their insulin, if they have a high potassium on their BMP, once you give them insulin, that potassium level is going to drop really quickly. So you need to be careful and make sure that you're monitoring their potassium levels, because if it drops too low, certainly you can go on and develop some severe arrhythmia. Okay, so what is this going to show you? The fingerstick glucose is obviously going to be really high. The CBC will often show elevated white count, even in the absence of an infection. So just because they have an elevated white count doesn't mean they have infection. That's why we're getting cultures. But do look for the differential in your white count. That might give you a hint. BMP will typically show a low sodium. The potassium will be variable. That's all in your kidneys. The sodium is going to be low because you're trying to pull back in potassium. The potassium, though, can be variable. So it may start out high, but ultimately it's going to go low, especially once you start giving them insulin. You may see an increased BUN creatinine ratio because they're volume depleted, low bicarb because of the acidosis, and increased anion gap. So this is an anion gap metabolic acidosis. So when you do your equation, you're going to have a high number here. And actually, if we go back to this patient and you look, 128 minus 13 minus 91 is 24. So she is definitely anion gap metabolic acidosis. Serum and urine ketones positive, urinalysis and culture, it'll show you glucose positive. But you want to look at that culture. It might not come until later on, but you want to definitely get a culture because that might show you if she's got a bladder infection. Look for other things like nitrates and stuff like that, though, too. ABGs will show you an acidosis, and EKG is variable depending on the potassium level, how severe it is. So the diabetic ketoacidosis typically shows up in type 1 diabetics in all ages. It usually shows up in patients with poor control. So teenagers who really don't like taking their insulin, they feel uncool taking their insulin, end up with DKA. Patients who are presenting for the first time with diabetes can show up with DKA. Or patients with diabetes who have infection or just got surgery, they're going to have a different insulin requirement, and so that's another way that this can present. Symptoms: fruity breath, abdominal pain, dehydration. Workup, we already talked about. Management, very first thing, fluid resuscitation. You want to monitor their electrolytes. Once their glucose drops below 300, you can change to D5 half normal saline. You want to be giving them insulin at some point, but fluid resuscitation first. Insulin, you'll give a bolus, and then you'll do an infusion. Once the anion gap normalizes, then you can start giving them subcutaneous insulin, but first you're going to be giving them IV insulin. Keep an eye on that potassium level while you're giving them insulin because it's going to drop. If it drops below 3.3, you want to stop the insulin and give them potassium, 20 to 30 milliequivalents per hour until they go back up above 3.3. If you're giving 20 to 30 milliequivalents per hour, you're not going to bump their potassium up too high, so you just want to monitor it. And once it's above 3.3, then you're good, and you can start giving them insulin again. If their pH is below 6.9, then and only then give them bicarb. So what do we normally see for blood pH? 7.3, 7.35 to 7.4, 7.45. Okay, so pH of 7.1, you might think, oh, that's really low, I should give them bicarb. No, bicarb only if the pH is below 6.9. So not very commonly are you going to be giving bicarb. Okay, so that is DKA. So the hyperosmolar state, that's such a mouthful, HHS, the hyperosmolar state, is type 2 diabetics, typically older patients who can't take care of themselves, they can't get to water, so they're usually dehydration is going to be what precipitates this. But infection can do it, as well as some medications. All of these things they kind of dehydrate you, but particularly diuretics. So beta blocker steroids and diuretics. These patients tend to be acutely ill, and that illness may have preceded their hyperosmolar state, or it may follow it. Dehydrated, invariably they're going to have altered mental status. Get a finger stick glucose, get BMPs, get ABGs. These patients will not have ketones. Okay, this is a non-ketotic syndrome. So, and then they tend to not have infections as commonly. So only get infections. I should have added a CBC in both of these. Both of these should say CBC too. You only really need to get cultures if your CBC indicates that you should. So if you have a high white count or something like that. Okay, both of these should have a CBC added onto it too. What do we do for these patients? Well, what's the precipitating cause? Dehydration. So you want to give them fluid resuscitation, monitor your electrolytes every 2 hours, and then that should be enough to correct their insulin. So only if their glucose remains elevated above 350 or so, only then do you give IV insulin. But you'll want them to start their insulin again once they're corrected. Their subcutaneous insulin that they're normally prescribed, if they're prescribed it. And most of them are. So this is how we go about DKA and HHS. So I wouldn't memorize this for the test. What I would remember for the test for step 2, step 3 is that your first step is to get IV fluids, and then all the things you should order, of course. So definitely very important: BMP, CBC, cultures, urinalysis, check ketones, and then fluid replenishment. Once you give fluids, you want to look at bicarb. You want to look at potassium. Okay, if once you start giving insulin, the potassium level drops below 3, then you want to give potassium, hold off on the insulin. If their bicarb is below 6.9, you can give supplemental bicarb. As far as insulin dosing, don't worry about that for the test. USMLE does not ask you about dosing. Okay, but you'll start out with IV, and then you'll give subcutaneous. Okay, so I don't want to bog you down too much with that. Question 9. We have a 67-year-old man presenting to the clinic complaining of changes to his eye. For the last 2 weeks, he's noted that his left eye does not appear normal, and he's got some difficulty seeing out of it in the dark. He is otherwise in relatively good health and denies other symptoms. He's on no medications. He has smoked a pack per day for the last 50 years, but denies alcohol and illicit drug use. He denies any other symptoms. He's 5'10" and 170 pounds. That's a normal BMI. I should have calculated that, but I didn't. Which is unchanged from his last visit a year ago. Vitals are within normal limits. Physical exam is significant for ptosis of the left eye, along with a fixed constricted pupil. Extraocular movements are normal. Neurologically, he's grossly intact. Which of the following is the best next step in diagnosis? A, head CT, B, slit lamp examination, C, EEG, D, chest x-ray, or E, anti-acetylcholine receptor antibody titer? Okay, the answer to this one, very classic USMLE question, chest x-ray. So what do we think this patient has? What kind of tumor? Yeah, lung tumor, but what's that kind of tumor called that causes this? First of all, what is this clinical picture? What do we call this sign? We call this Horner's sign. Okay, so what kind of tumor typically causes this? A lung tumor, yeah, but what kind of tumor? Starts with a P. Pancoast tumor. This is a pancoast tumor. A tumor in the apex of the lung. Okay, so he's got Horner syndrome. Horner syndrome can be caused by all sorts of things. In addition to lung tumors, it can be caused by migraine. It can be caused by brainstem tumor or stroke. Even a dissecting carotid aneurysm can cause it. But why do we think this guy has a lung tumor? Well, 1, it's common. 2, he's got a big smoking history. 3, he's old. He's got all these risk factors for a chest tumor. And a chest x-ray is something that's really easy to get. Before we subject him to a head CT, before we subject him to slit lamp examination, if we think this is something primary to the eye, which it isn't, we're going to give him a chest x-ray. Okay? And a chest x-ray will likely show a pancoast tumor, one of the more common causes of the Horner sign. Okay, so this is Horner sign. It can be more obvious or it can be really discreet, like this guy's is. So if you look, his right pupil is slightly more constricted than his left pupil. And you can see a little bit of droopiness. If you ask him to open his eyes as much as he can, you'll see some asymmetry. And then if you may feel some increased warmth on one side than the other, on the affected side, and it may be drier. So this is Horner syndrome. Horner syndrome is pretty complex in why it happens, but if you know the anatomy, if you just briefly understand the anatomy, you will kind of understand why this occurs with the things that it does. So here we have the hypothalamus, and you have first order central sympathetic fibers, which come out of the posterolateral hypothalamus. It should be a little bit further back here. So it comes out back here. It comes down through the brainstem. That's why brainstem tumors and brainstem strokes can cause Horner syndrome, because anything that cuts off this whole circuit here is going to cause Horner syndrome. Okay, so it comes down the brainstem, and then it terminates in the spinal cord, roughly at the level of C8, T12. So pretty far down. So it comes down by the apex of the lung. At the level of, sorry, did I say T12? I meant T2. So C8 to T2. So at the level of T2, it's going to come out, T2, T1-ish, and then enter the central sympathetic chain. which is right here. And then once it comes out there, it starts to come back up. And here it goes again by the apex of the lung and by the subclavian artery. And then it synapses roughly at the bifurcation of the carotid artery and then continues to ascend back upwards towards the eye. And so that's why if you have a carotid aneurysm, you can get impingement on this nerve. Okay, so it comes back up, and then it enters the eye through the ophthalmic branch of the trigeminal nerve into the iris dilator muscle. Okay. So just because of its anatomic proximity to the apex of the lung, that's why it can. That's why tumors of the apex, those Pancoast tumors, can cause the Horner syndrome. Okay, so this is a Pancoast tumor here on the left side, in the apex of the lung, and this can be really any kind of tumor, any kind of lung tumor. I don't think it's associated with any specific type. I might be wrong, but what you need to know is you need to get a chest X-ray on somebody coming in with Horner syndrome. Okay, and finally, question 10. A 21-year-old man presents to your clinic interested in reducing his risk for HIV. He is sexually active with both men and women and has read that there are medications available to help. He was last checked for HIV 4 months ago and was non-reactive. That means negative. He has not had sex since then. He quote-unquote usually uses condoms, but wants to take extra precaution to reduce his risks. He has no history of STDs. He does not smoke, drinks alcohol socially, and denies illicit drug use. Vitals and physical examination are normal. Which of the following would be the most appropriate next step in the management of this patient? A. Tenofovir emtricitabine. B. HIV ELISA, that's just the HIV test, followed by tenofovir emtricitabine. C. Tenofovir emtricitabine or eltegravir. D. HIV ELISA, followed by tenofovir emtricitabine or eltegravir. Or E. Reassurance and encouragement to improve safe sex practices. Okay, so I'll give you some time to pause it if you want to mull this over. So we got a 21-year-old guy who wants to reduce his risk for HIV and wants to know if there's medications available. What are his chances of having HIV right now? Pretty low. Okay, he had an HIV test 4 months ago, was negative, and he hasn't had sex since then. So unless he's doing drugs that he's not telling you about, he probably does not have HIV. So if you were taking the test in 2001, the answer would be E. Okay, because there'd be nothing we could do for him. All we do is tell him, use condoms more consistently, and you don't have HIV right now. Almost certainly, we'll give you another HIV test right now if it makes you feel better. But otherwise, you're fine. Just use condoms more consistently. But in the last 10 years, the FDA has approved a medication that reduces your risk of getting HIV, and this is called PrEP. Pre-exposure prophylaxis. So the answer is not E. It's A, B, C, or D. So the question then becomes two things. Do we need to give him an HIV test right now? And what is the medication that's approved for PrEP? So first question, do we need to give him an HIV test right now? Well, he had one 4 months ago. It was negative, and he hasn't had sex since then. So we already established his risk of having HIV is very low. And the answer to that is yes, we do need to give him an HIV test. There's a possibility he may have fallen within the window period. So he got HIV, he was exposed to it a week before he got the test. He hadn't seroconverted yet. It came back negative. It was a false negative, and now he's got HIV and he doesn't know. That's a possibility. Very low possibility, but it's a possibility. Either way, we need to get an HIV test. Okay, so A and C are out. That's just the recommendations from the FDA. So between B and D. Now the question is, what is the medication for PrEP? And the answer is B. Okay, tenofovir emtricitabine or eltegravir would probably be effective for PrEP, but we don't need to add that third medication on. Tenofovir emtricitabine or eltegravir would be a great drug for post-exposure prophylaxis. There are multiple regimens for post-exposure prophylaxis. This one's the most common one, but he's not post-exposure. Okay, so post-exposure prophylaxis would be something like this. He comes in, he tells you, Doc, I had sex last night, it was unprotected, it was some stranger, and the stranger texted me back this afternoon and said, by the way, I have HIV, you should probably do something about it. That would be a post-exposure prophylaxis situation. This is pre-exposure prophylaxis. He has no reason to think he's been exposed to HIV since he had his last test, but he wants to reduce his risk of developing it in the future with future exposures. So what this is pre-exposure prophylaxis, and for pre-exposure prophylaxis, the medication is tenofovir emtricitabine, also known as Truvada. Okay, so we need to get an HIV test on him, and then we can give him Truvada to reduce his risk of developing HIV in the future. So pre-exposure prophylaxis, or PrEP, is recommended in a variety of patient populations. The first would be HIV-negative patients in a sexually active serodiscordant relationship. All that means is the patient's HIV-negative, the partner's HIV-positive, and we want to reduce the risk of the patient developing HIV. So one particular patient population you might see this in would be women who are HIV-negative and their husband's HIV-positive and they want to get pregnant. So what you would do for that couple is you put her on PrEP. You'd want to make sure that he's undetectable, ideally, so he needs to be on some kind of medication that's going to reduce his viral load. That would be a heart combination, like a triple therapy. And then that would minimize the risk of her developing HIV. Would it reduce it to zero? No. But this is why we give PrEP for HIV-negative patients in a sexually active serodiscordant relationship. Really anybody, though, in a serodiscordant relationship. So classically, you see it in women who want to get pregnant, but anybody who is HIV-negative, who's got a partner who's HIV-positive, great candidate for PrEP. Men who have sex with men or transgender women, these patients are at very high risk for HIV because in the United States, men who have sex with men have a much higher incidence of HIV, and then transgender women tend to kind of circulate among the gay community. They have a higher rate. So the FDA gives a set of criteria for this population, but I have some disagreements with this, which I'll delineate in a little bit. So if they've had sex without a condom in the last 6 months, if they've had any STD in the last 6 months, or if they have sex with, they don't regularly use condoms during sex, or they have sex with people with unknown HIV status who are at risk of contracting HIV. In other words, if they're not using condoms and they have partners who are at risk of getting HIV. So the way I look at this is if the patient comes to you wanting PrEP, they're probably at high risk for HIV because it takes time to set up an appointment and come into your doctor and gather up the courage to say, I want PrEP, because it's kind of embarrassing. And a lot of these questions are very personal, and patients might be shy and they might not tell you everything. And so the way I look at it, and this is just me personally, but if the patient says they want PrEP, they're probably at high risk, and so we're going to work them up and give them PrEP. Okay, and then of course, people who shoot up drugs, they're at high risk. So the one caveat you have to take from this, and this is important for any test question, is that you want to know if they're HIV positive, because if they're HIV positive, they're going to be on HAART. They're not going to be on PrEP. And then if they're renally compromised, because tenofovir it's excreted, I believe it's excreted through the kidneys, and it also is nephrotoxic to some degree. So you want to make sure they're not renally compromised. So we're going to get an HIV test on all of these patients, and we're going to get renal function tests on all these patients. But once you do that, if they're HIV negative and their renal function is normal, then you can send them off with PrEP. And by renally compromised, we mean anything of a creatinine clearance below 60. If they're 61 to 90, then you got to be careful, but it's technically not contraindicated. You need to get an HIV test before starting PrEP. I cannot emphasize that enough. Okay, it needs to be done. You want to reevaluate them every 3 months. Why do you want to do that? Well, what's their risk of getting HIV if they're on PrEP? Is it zero? No, it's not zero. It's very low, but it's not zero. And there's a few things that can go wrong. They might miss a dose. If they miss a dose, boom, their risk goes way back up, even by missing one dose. Also, it's not zero to begin with. Okay, so if and a lot of these patients are going to come out and they're going to say, well, I'm on PrEP, I don't need to use condoms now. I'm telling you, people do this. Okay, I know people who are on PrEP. and they do this. Okay, so they need to be reevaluated every 3 months. You're going to get an HIV test on them every time they come in, because if, let's say, they're on PrEP and they become HIV positive, it can happen, and they continue taking that PrEP, it's not going to help suppress their viral load count. All you're going to do is expose that HIV virion to tenofovir emtricitabine, and it can become resistant to those agents. And so you want to know right away. You want to cut it off at the butt, and you want to get them on HAART as soon as possible. And that's a new recommendation, by the way. We used to wait until their viral load count was high enough, or their CD4 count was low enough, but now we just stick them on antiretroviral therapy as soon as they're diagnosed. So the medication for PrEP is tenofovir emtricitabine, and the adverse effects are they're minimal. I mean, these are what's listed, but lactic acidosis, nephrotoxicity, quite rare. Dizziness, nausea, and diarrhea are the most common. Emtricitabine, lactic acidosis, hepatotoxicity, headache, nausea, and rash. The most common side effects with the Truvada is going to be flatulence and diarrhea, but pretty low profile of side effects. It's not very common. So what I want you to take from this, get an HIV test before you start PrEP. Give PrEP to anyone who asks for it, as far as I'm concerned. But these are the recommendations. And it takes about 2 to 4 weeks for PrEP to kick in. So make sure the patients know that. Okay? Don't go off and have promiscuous, unprotected, condomless sex tomorrow. And it takes about 2 to 4 weeks. And even then, your risk is not zero. So it's ideal that you continue using condoms. This is to supplement condoms. Okay? And with that, thank you for watching, and I will see you later.